Joining us today is Dr. Patricia Zehr. She has been practicing since 1988 and specializes in obstetrics and gynecology. She practices at the Group Health Center in Sault Ste. Marie. Welcome, Dr. Zehr. Thank you for joining us today.
Thank you, Tara.
Can you tell us a little bit about yourself and how you became interested in women's health?
Yes, I've always been very interested in women and children's health. Prior to coming to Sault Ste. Marie, I was a nurse and I worked in the Northwest Territories. And my experiences there really led me to further my education. And I was actually going to become a pediatrician, but I became very passionate about women's health during my training.
That's quite an interesting adventure that you've been on. So you were part of another related healthcare profession previously,
Yes.
and you had worked in the Northwest Territories. What was it
Yes.
specifically about your experience that made you shift gears from looking at pediatrics to shifting towards women's health?
Well, they're very related, women and children's health. And it just seemed to be a natural progression. But I guess near the end of medical school, doing my obstetrical rotation, doing some deliveries, it really catches you. And then I changed my mind and decided to apply to OBGYN instead of pediatrics.
Yeah, that's so neat. And, being present at a birth is quite a momentous experience that you can be there to support a woman at a really critical time in her life. And of course, like you said, women and children's health is very much linked.
Yes.
That's amazing. Thank you so much for sharing your story. I'd like to hear more also about who are the typical patients that you see.
Well, I have a very interesting office population that I see. We're very fortunate in our community to have a really nice colposcope that we have at the Group Health Center, and we've had it now for just over 2 years, and it's an amazing educational tool. And I can use it because I see everybody from little children to the geriatric population with various problems. And with this colposcope that I have, and we'll talk more about colposcopy when we talk about abnormal paps, but with this colposcope, I can take a picture and put it on a screen, and the patient knows exactly what we're talking about. It's a really valuable tool.
That's pretty amazing. So what are the types of responses that you get when your patients are able to actually see this visual of their bodies?
It's very positive, and all the others are very interested, first of all, being educated about their own body. But secondly, depending on why they're there, if it's something that we're treating, then we can look at different time frames and they can see how the medication may have helped or not helped.
hmm Oh, that's incredible. So it's also a monitoring tool where there's the empowerment of being able to have that reflection of a treatment option and seeing how that's progressing.
Yes.
That's amazing. And so can you tell us too about women's health exams? Because the exam schedule has really changed over the years. If you could tell us about what the exam guidelines are now, particularly for pelvic exams, it would be really great to hear.
Well, it shouldn't be controversial, but it seems to be controversial, and it's different from province to province. And in Ontario, what gynecologists use are the recommendations from Cancer Care Ontario. And so that has changed. I've been practicing for 28 years, and we used to do and recommend pap smears when a young woman became sexually active. And now, regardless of sexual activity, it's 21 years of age. So
So
things have changed, although a lot of women, I think, are still getting PAPs earlier than 21. But 21 is the recommendation that I follow.
okay, which again is like really helpful to know. So that would be the first time that a woman has a pap smear would be at age 21, like you said, regardless of sexual activity. And then also if women are, past the age of 21, what's the recommended guideline for pap testing?
Headline, if the is negative, is every 3 years up until the age of 70. And if the women's PAPs in the previous 10 years have been negative, we stop screening after the age of 70. However, if dysplasia, precancerous cells, are picked up prior to that age, then these women will still need to have pap smears.
hmm Which again is like really helpful to know to sort of set the record straight on what that recommended schedule looks like at this time. As you mentioned, it has changed over your 28 years of practice.
Yes, yes.
Now, why is screening like pap testing so important for women's health?
Well, it's hugely important. And before I address your question, I just want to say something because I don't want to forget to mention it.
Sure.
The other thing when a woman is having a pelvic exam, she should make sure that her healthcare provider also does what's called a bimanual exam. So a glove on the abdomen or hand on the abdomen and a gloved hand in the vagina to feel, is the uterus normal? Is there any pain? Are the ovaries normal? Because when we're talking about screening, there's no effective screening for ovarian cancer. So I think it is important that if you're there, you're having a PAP, you should also have a bimanual exam.
Thank you for mentioning that. Again, a really critical piece to mention, as it should be, a standard of care for practice that you are assessing in that way, because women also might not know what to look for themselves if they're checking their own bodies. But with the
Right.
sense of touch that you develop as a healthcare provider, you're going to notice when something is different or abnormal, right?
Exactly.
Thank you
Exactly.
for mentioning that. And to the question about why screening tests like pap testing are so important, can you share a bit about that?
Yes. The screen, by definition, is applied to a normal population. And so you want to pick up something that is treatable. So if you have a pap smear and the cells come back abnormal, we have gradation for how abnormal. And I generally draw a diagram for my patients showing them that you can have precancer or dysplasia, which is not cancer. And right now, the protocol that we use is low grade or high grade. So if it's low grade in a non-smoking woman, because smoking is a huge risk factor for precancerous and cancerous cells on the cervix, in a non-smoker with low grade, 30 to 50% of the time, it will go away on its own. So I talk to them about the fact that it needs to be followed. If it progresses, crosses the line into high grade, then it must be treated because we know if it's not treated, then eventually it will cross over into cancer of the cervix. And no woman should die of cancer of the cervix in Canada in 2020. It's highly treatable and highly diagnostic if you just come to have the screening test done.
Thank you. Yes. I really want to emphasize that point that the screening is so essential. And that is, just lends to that point because there's prevention that can be put in place if treatment's needed, or options can be explored at that time, but it doesn't, like you said, have to get to the point where a woman has developed a cancerous process and then you're in a different boat.
I'm probably going to segue right into something you're about to ask me, which is about human papillomavirus.
Yes.
So, human papillomavirus has been around for a long time, and we have had different approaches to it, and we have learned so much about it in the past 2 to 3 decades. There are many, many strains, some that are associated with venereal warts, and some that are associated with cervical cancer. And we now have the technology where we can pick that up on a pap smear. However, there's a big caveat here, and it is something that I cannot emphasize strongly enough. And I don't know how we're ever going to change things because we've known for a long time that doing an HPV test is actually more important than doing a pap smear. Because if a woman has no HPV, she is at a very low risk of having an abnormal pap smear. If she carries high risk HPV, then she's at very high risk, especially if she has other risks such as smoking. And someone who tests positive for high risk HPV, this group, these women must be screened every year once they have a negative pap. And then otherwise they get funneled into, I mentioned earlier, my colposcope, they get funneled into the colposcopy unit where they undergo investigation, microscopic assessment, the cervix, plus or minus biopsies to make the diagnosis of precancer generally. Rarely is it cancer, but we don't want to go there.
Definitely. I think you bring up some really important points there, and I appreciate your perspective on that. So as women, how can we ensure that we might be getting screening then for HPV testing? Is this a standard of practice that's in place with our family doctors or nurse practitioners in Ontario, or is this something that we might have to ask for ourselves?
Probably, unfortunately, you'll have to ask. Now, if you're in a gynecologist's office or getting ready to be discharged from a colposcopy clinic, then it makes it easier to triage, to separate the high risk from the low risk patients if we have that test. And we can have it, but it's not paid for by the ministry. So it costs $90. It can be done reflexively on the pap. So all we do is a pap smear and write on the rack, please do HPV testing. And they'll do it, but then they send the patient a bill for $90.
But I mean, considering that this can really help a woman understand if she's at risk or not, that would be a really worthwhile small investment, putting it in perspective with the potential, risk of what the worst outcomes could be. So $90 in Ontario could be like a really small investment to make for your health for this level of understanding that can lead to working on, again, prevention or exploring treatment options.
Well, you're right. However, a lot of my patients can't afford $90 for an HPV test. Even though they might want it, they may be on ODSB or not working. And I guess because I've been doing this for so long, probably it was around 18 years ago, we had a pilot project from the ministry in Sault Ste. Marie, and we were able to test women for free. And then the pilot project ended, and then the HPV test disappeared, and now it's back, but you have to pay for it. Mm-hmm. And so I was at a conference in January, and I spoke to Dr. Joan Murphy, who's in Toronto, and one of the leading she's a gynecological oncologist, so she does cancer gynecology, but she is a passionate worker at screening and prevention, and she's been advocating for HPV and written papers and given talks and attended meetings. And I spoke to her at the meeting. I said, where are we? Are we going to see this like in my lifetime? And she's very optimistic. So I'm hoping, because it would actually save a lot of money in the long run. We wouldn't be doing as many pap smears, and we wouldn't be inflicting biopsies unnecessarily on women in the colposcopy unit. So it makes good, I think you could write a good business plan for it, and it makes a really good health plan for the woman.
Yes, absolutely. Thank you for sharing your insider knowledge about that. I think it's, again, really important to have these discussions and to bring this awareness to the public. And if there's anyone out there who's watching right now who wants to take this on for, advocacy for women's health, this is a really important topic, is what I'm hearing from you.
It is.
Wonderful. Thank you. I'm also wondering about, a little bit more, if you could share about cervical dysplasia, cervical cancer. We can talk about maybe those two topics differently. What are signs and symptoms that a woman might experience if she has cervical dysplasia, for example?
Well, there are no signs for cervical dysplasia. For cervical cancer, bleeding, abnormal bleeding. So perhaps bleeding after intercourse, bleeding in between periods, heavier bleeding. But that's cancer. That's very different. So for precancerous cells, most of the time there are no symptoms.
Which comes back to the whole importance of screening again, because you don't know, and then you'd have to, like you said earlier, to triage high and low risk.
Right.
hmm Thank you. And so with respect to cervical cancer, I know you've mentioned one huge risk factor is smoking. What are other potential risk factors for cervical cancer?
Well, I'm going to put vulvar cancer in there as well, because vulvar cancer is also a risk with smokers, and HPV. So if you carry the high risk HPV, you're at increased risk of getting cancer of the cervix or precancerous dysplasia, but you're also at increased risk of getting dysplasia of the vulva. So that you may be symptomatic. You might notice the lesion on the vulva that might bleed, or it burns, or it hurts, or it feels different to you. And then that might bring you into the physician, who may or may not make the diagnosis or refer you for a colposcopy and a biopsy.
hmm
So really, smoking and high-risk HPV are the biggest factors. And as far as HPV goes, we don't do it in women less than 25, because most of those women will clear it on their own. Who are over 25 can have the HPV testing done. And the other thing is the immunization. So we have an immunization against HPV, which has been around for a while, and is offered to elementary school kids, or you can get them yourselves. They're expensive. That's the problem. There's three. You need three, and it costs about $900. So if you don't have a drug plan, then again, that's very expensive. But a lot of drug plans do cover it, so that is nice.
hmm I think it's important too to speak to, what could be done. And I appreciate you mentioning that. If a woman recognizes that she has risk factors, what could she do right now for her health?
Well, we talked about immunization against HPV, and that's very helpful both to prevent and perhaps to treat disease, as well as quitting smoking, because smoking and HPV together are like lighting a match for progression of whatever is going on. And then really the only other thing you can do is to lead a healthy lifestyle to keep your immune system boosted. So other women who are at risk of cervical dysplasia or getting HPV are those who are immunocompromised. So someone who's HIV positive, they need a PAP every year because they're at risk. Someone who's received an organ transplant and is on immunosuppressive medication, they're going to need more often screening as well because they're at increased risk. So if you're on immunosuppressive therapy because you've had a life-saving transplant, there's not a whole lot you can do other than to try to get rid of your other risk factors and to lead as healthy a life as possible. But for the average woman who isn't really immunosuppressed, then you still want to boost your immune system. So eating good food, getting regular exercise, getting enough sleep, avoiding smoking. Those are it sounds all motherhood, but it's really true. These are really, really important things that you can do to stay healthy.
Absolutely. So often it comes back to those fundamentals and how we just taking care of our overall health and well-being that then supports, proper function of our bodies as a whole.
It's true. We have to keep educating women to do this because women historically are not good at taking care of themselves because they're the caretaker for so many others. Their partner, their children, their friends, and I have to talk a lot to women about taking care of themselves. I like to use the analogy of in the airplane, you have to put your own oxygen mask on before you can help your child sitting next to you. So women really need to take better care of themselves than they do.
Very true. And I think that's an excellent analogy to really think about, because you can't help others as or be as fully present as maybe you want to be if you're not caring properly for yourself. And I have to say that in every single interview throughout this series, this point has been mentioned. So I really hope that women listening are tuning into this idea that it's so incredibly important for us to start to put ourselves first and prioritize our own health and well-being, because we won't be there for the people in the state that we want to be eventually if we're burning out and not taking care of ourselves, and we're developing different chronic diseases because of pushing ourselves too hard and not putting in the energy and effort for self-care.
Absolutely. I agree.
So earlier you had mentioned some potential obstacles that have to do with, finances. What are some other common obstacles that women might encounter who you are working with or treating?
Fear. And that's really unfortunate because there are a lot of women who are fearful of perhaps it's an intimate examination, so fear of the pelvic exam, fear what you're going to find. A lot of women have abnormal bleeding and do not present or tell their doctors, or maybe they don't have a doctor, in which case they would have to go to the hospital and then either be assessed or be referred. It's very unfortunate, but the fear does keep women away, and sometimes it keeps them from coming back for the appropriate therapy, which for me is extremely disheartening because this is such a treatable disease and you can prevent it from becoming cancer. That's the whole purpose of the screening, is to pick it up early, treat it before it becomes cancer.
Very true. I could see how fear could potentially get in the way. I mean, I've experienced that myself, just generally speaking. Fear kind of as an obstacle for me to be moving forward on something that I know is important. So I'm really glad that you mentioned that, so women can sort of reflect on if they're allowing fear to hold themselves back and pursuing health or treatment options that they might require at this time. I think it's a really important piece, and we all experience fear as human beings, and I'm really glad that you're bringing that to the forefront.
And, I would like to say that pelvic exams should never hurt. And if, you are in charge of your body and your examination. So if someone is trying to do a pap smear and it's hurting you, then you have to ask them to stop. You have to have the autonomy to do that, but you still need to have the examination done. So either they use a different speculum, or you come back another time, or you go to a different provider, but you still need to be assessed. You need to have that examination.
Very true. Sometimes women, I've heard these types of things in my office. They don't always feel empowered to have that communication, but if you just have that communication, I mean, you know your body best and you know what's happening sensation wise. So if you can communicate to the healthcare provider, then they can adjust, but they're not necessarily going to know that you might be experiencing discomfort unless you vocalize that. And that's okay to do.
And then the other part of this is that when you're afraid or anxious and not verbalizing, what happens, right? Your entire body gets tense and tight, your muscles get contracted, and then it hurts more. So it has to be the discussion between the woman and the care provider. You're right. We both have to give feedback and talk and explain what's happening
Yeah,
and what it
absolutely.
feels like. Mhm.
Absolutely. And I also, resilience is a topic that is near and dear to my heart. And it's also something that is so important for women's wellness. What does becoming more resilient mean to you? And how does this apply to the women that you treat?
Resiliency is talked about a lot. It's talked about a lot with people who have burnout. As you know, being a naturopathic doctor, you see a lot of people, like women, men, I'm sure, with burnout. So I think resiliency is, um, I think you can create it. I think some people are born with resiliency than others. You can still learn it, create it, mindful about of what's happening. So resiliency is basically, in my mind, it's well, surviving. But having said that, I'm going to quote Maya Angelou when she said that surviving is important, thriving is elegant. So I kind of think about that quote when I think about resilience. It's kind of pulling yourself up, being strong, and I like thinking about thriving, not just surviving.
Thank you so much for sharing your perspective on resilience. And that is such a great quote. And I think it really illustrates the point. It's going beyond survival. Um, and I want to also thank you, Dr. Zehr, today for your time, for all your sharing, your clinical perspective on things, the education around women's health topics, how to approach conversations and the communication required, the treatment options, all of the wisdom that you shared. I have no doubt that so many women are going to benefit from everything that you shared today.
Thank you. I've really enjoyed speaking with you, Tara.
Thank you so much.